Welcome to Heartbreak and Hope with Pat Barbarito, the show that explores how to build up or break down any relationship with confidence, clarity, and compassion. I'm so excited about today's episode. We are going to be talking about sexual health for women over 50. Now, according to the National Institute for Health, 57% of people over 60 are sexually active. And we hear a lot about sex over 50, but usually it's about Viagra, Cialis. We're inundated with commercials and information about men's ability to have an erection. Okay, we get it. An erection's necessary for intercourse. We all know it. But we really don't talk a lot about women's sexual health, their desires, our physical changes, issues that will enhance or interfere with sex. This isn't about making moral judgments on who people sleep with and who people have sex with. But the reality is, at a certain age, sex is viewed differently. Now, for myself, I was absent from the dating world for about 10 years after my marriage ended. And I found that at about 7 years ago, at age 60, when I re-entered the dating world, well, things were different, especially with sex. Well, the great news is that when I re-entered the dating world at 60, my confidence level was higher, my decisions were more sound, and my discretion had evolved. But the reality is aging does have an impact on sexuality. And while that could be heartbreaking and disappointing for people, there's a lot that could be hopeful. And once you hear from our guest today, Dr. Anika Ackerman, you're going to be full of hope. I promise you. But before we talk to Dr. Ackerman, I want to give full credit for this episode to one of our listeners. She also happens to be a friend of mine. She's 60, been married for over 30 years. And she reached out to me saying that she thought women's sexual health would be a great topic. And when I spoke with her and I dug a little further, this very refined, very elegant, quiet friend of mine talked a lot about reestablishing intimacy with her husband during the pandemic. And this listener, like so many of us who really weren't brought up to talk about sex, particularly women of a certain age, we never talk about sex, even to our closest of friends, at least not at this level. She wanted to talk about it. And she said, nobody talks about vaginal dryness, the inability to experience penetration, all those realities of sex at a certain age if you're a woman. That leads us to our guest, Dr. Ackerman. Dr. Ackerman is a board-certified urologist. She's tackled the issue of sexual health by embracing the topic. She has a TikTok account with hundreds of thousands of followers, and her social media presence is extensive. She uses it as a platform to educate the masses about sexual dysfunction and shatter the stigma surrounding discussions on sexual health. Now, I admit in my preliminary conversations with her, even I blushed, and it's really hard to make me blush. But she has managed to transform an uncomfortable conversation into a captivating and educational conversation. Her goal is to make sexual health enjoyable and enlighten her audience. She's normalizing a discussion about sexual health and dysfunction and breaking down barriers. Welcome, Dr. Ackerman.
Thank you so much. It's so exciting and wonderful to be here and share some stories and knowledge and anything I can with your audience.
How does a successful board-certified urologist become drawn to women's sexual health? Because that's a rare specialty.
Right. You don't think urologists. Most people ask me, why did you go into urology? Do you enjoy prostate exams and treating male erectile dysfunction? And obviously the answer is no. Nobody enjoys prostate exams, neither the examinee or the examiner. But this is a field that is not widely taught in medical school or residency. There's no specific specialty that takes ownership for sexual health on the female side. Male sexual health is clearly urology. Urology writes the prescriptions for Viagra, like you mentioned, Cialis, and whatever other treatments men will need beyond that. But nobody writes Viagra or Cialis for women. It just never existed until recently. Any person that is a sexual health practitioner or sexual health expert in this field has sought their own training, has gone to meetings and joined the International Society for the Study of Women's Sexual Health, or ISWISH, because it's the main group that is delving into female sexual health and figuring out the anatomy and what we need. And so urologists, along with some gynecologists, but not many, some urogynecologists, which is a hybrid of the two practices, and some general practitioners out there have taken ownership of this female sexual health field. And it really is on the brink of, I think, an explosion, and more doctors are going to learn about it, hopefully, and be able to disseminate more knowledge. This is not something I thought I was going to be doing when I started residency. I knew I wanted to be a urologist from the fact that I had some urologic conditions as a younger person. I just think I was drawn to the field for the fact that it has surgery and we treat men, women, and children. But the sexual health aspect wasn't there until I graduated and realized that there was a need, and it was an unfulfilled need. And I joined that group that I mentioned, the ISWISH, which, if you're looking for a provider in your area, it's something to definitely look into.
Could you tell our audience about that?
Sure. So International Society for the Study of Women's Sexual Health. The acronym is ISWISH, ISSWSH. There is a website with all the ISWISH providers on it. And if you look these people up, you know that they are knowledgeable in the field of female sexual health. So if you're in the rural town of Illinois somewhere and you need to find a provider that may know something about what we're talking about today, you would go to that website, and there may be a provider, nearby somewhere, but that's really the best resource to find someone who knows about female sexual health.
That's a great resource, and thanks for sharing it. Before we talk about sort of the mechanics of it, one of the things that occurs to me is that it's uncomfortable to ask your doctor about sex and talk about the fact that you're having sex, you're not having sex. It's embarrassing for women. So how do you address that?
It's definitely going to be hard for some women to talk to their primary care who they've seen for 15 years, and they know their entire family and their GYN who delivered their babies. They don't want to, bring this up to them. So if you're looking for someone, anyone who's on that ISWISH website is going to be very comfortable talking about female sexual health. That's the reason they're there. They're paying to be a part of that membership, and they're paying to have their name listed there. And they're interested in female sexuality, and they want to treat those patients. I understand that it may not be easy to talk to your long-term provider about, your low libido and your painful intercourse. So it may be something that, either you have to ask your primary care if they refer to anyone, or, do some research on your own and look on that website I mentioned.
I think a lot of the issue with particularly women over 50 and certainly over 60 is desire, how to sort of spark that up. Do women come to you and say, yeah, not really feeling it lately? And how do you address that? Not just medically, but are there other ways to address it?
Yes, of course. Low desire, low libido is present in women as young as 30, and it's because of hormonal fluctuations mostly. There's a DSM diagnosis, which means a real medical diagnosis like diabetes. It's called hypoactive sexual desire disorder, or HSDD. And you could diagnose someone with this, and we now have 2 FDA approved medications to treat it. It definitely is more prevalent as you get older. I have couples come in, and especially I'm a urologist, so I see their husband and they got their Viagra, their Cialis, and they're ready to go. And then she's just there at the office visit and says, oh, he's doing great, but I just, never in the mood. So couples counseling is something that, may be able to help that. But really what it comes down to fundamentally is hormones and neurotransmitters in your brain, which unfortunately do require medical treatment. So the other half of that diagnosis, the hypoactive sexual desire disorder, is it has to bother the person. So if a woman has no desire for 6 months and they don't give a shit, then they don't have it. If they have low desire and it bothers them, then they are characterized as HSDD, and we treat them.
You just raised a great point, right? So if it doesn't bother them, if somebody doesn't have a partner or isn't interested in a partner, I respect it. I get it. The problem, though, and again, I'm a divorce lawyer, so I see this, is that if their partner has the desire and they don't, let's talk about the need to keep intimacy in a relationship, because it is one of the things that I see that ends a marriage or ends a relationship. If you're okay with the lack of desire, but your partner's not going to work out real well for you.
And that you have to sort of tease out amongst the relationship. I mean, if a woman is having low desire and she cares about her husband and wants to make her relationship better, then she has HSDD. That's bothering her. So I would treat that person. There's other things you can do. There's a great app. It's called Rosy, ROSY, and it's a erotic stories app that you sort of scroll through and you can read, and it's supposed to put you in the mood. There's a lot of data showing that if you watch pornography or read intimate stories, that'll put you in the mood. So you can start, if a woman is really against, medical treatment for this type of condition, you can start with things like that. I mentioned before, there are relationship counselors, obviously, that will probably be able to build a stronger foundation, and maybe that will lead to more intimacy. My role as a urologist really comes down to they've tried all these other things and now they want to try flibanserin, which is Adye, or Vyleesi, which are those two FDA approved medications that will really increase your desire. Or we're going to talk about hormone supplementation in a woman who's, within 10 years of menopause.
So those medications, are they testosterone? Is that what that is?
No, testosterone.
Because that's what I would think,
And we can get to that in a bit. And I'm impressed that that testosterone for women is a thing, because a lot of people don't know that. But the two medications that are FDA approved now for hypoactive sexual desire disorder or simply low libido actually work on the neurotransmitters in your brain. So they're increasing dopamine, the hormone that makes you want to have sex. One of them is an auto injector. You literally give you a shot in your thigh 45 minutes before intercourse, and it puts you in the mood. I have personal experience and very close family and friends who've tried it, and it's really kind of a wild medication, actually. I recommend it to my patients, so I wanted to try it for myself, and it works.
I am amazed that people haven't heard of this. I haven't heard of it, and I'm always reading and looking. So this is really, really, in my opinion, shocking information. I can't imagine we're not going to have a rush on that drug after this episode. I know you've written about this, and I know one of the things you say kills libido is not enough sleep, too much alcohol, too much food, stress, and boredom. So those are sort of libido killers. But there is a point where if it's dead, it's dead. It doesn't matter why.
Right. And this Vyleesi, so that's that auto injector, it's really something that you don't have to use all the time. You don't have to remember to take a pill. So, if you're an older couple that wants to get in the mood once a month, which, I think that's the norm for a lot of people who are empty nesters and beyond, and, they just want to keep it active, but they don't want to have sex 3 times a week. I think it's a great solution.
Or they're not watching a lot of porn at 85 years old.
That's right. Maybe they'll read an erotic story on that app, but I really do like Vyleesi for that reason. It doesn't have side effects other than nausea, and that's usually with just the first dose, and not everyone gets it.
So it's like a Viagra in the sense of you take it as needed. So in anticipation of the event. And is that for any age? Yeah.
It's FDA approved for premenopause, but I prescribe it for postmenopause, and they're doing the studies now on that population. The FDA hasn't approved it because there's been no studies on the postmenopausal population yet, but it's there and it works.
So that's fascinating to me that the way you speak about sexual health and sex and that you've tried it is so disarming that it makes it, I feel like, well, we could talk about this on this episode because quite frankly, I'm 67 years old. I can genuinely say, as open as I am, I don't have this level of conversation with even close friends. And I have a lot of close friends, but there's something so disarming about the way you talk about it that it's refreshing. So thank you for that.
It's just medicine to me. It's not personal. And are there moments during my office hours that it's like TMI? I keep a straight face, but sometimes it is TMI. Like,
of course,
the patient says, this position doesn't work for me. I get more irritation when, I'm on top, whatever it is. I poker face, just, sort of keep it moving. But I think I've desensitized a lot of my friends, definitely my family members, by them just seeing my social media and knowing that I'm like this sex doctor now. And we sort of can talk about anything without having everyone around me blush.
Well, it's really a liberating conversation because, again, we're all enlightened. We're all liberated. not at this granular level about sex. So this is terrific. And I think it's going to be helpful for our listeners. You talked about menopause. So when does menopause happen and what happens to your body in terms of your sexuality?
Menopause in the United States, the average age is 51. We all know average means that some women are going through it in their 40s, some women are going through it in their later 50s. Perimenopause is a time within 10 years of menopause when your hormones are fluctuating wildly. So you can have symptoms of menopause during those 10 years prior that can really screw up your sex life and sex drive and your vaginal feeling and irritation and dryness. And so throughout that time, you can have sexual issues. Believe it or not, you can actually become more sexual in that time because there's these wild fluctuations where your estrogen is sky high and then low. And so you may feel even more sexual in your 40s. I've actually done social media posts about that, and I've seen women respond that that's true. I'm not quite there yet. I'm in my late 30s, so I can't sort of relate to that. But there's this, wide window for women who are going through their changes where they may feel all kinds of things. And, vaginal dryness, painful intercourse, low
So let's
libido.
start with them one at a time. Vaginal
Yeah.
dryness. I think that's
Yeah.
something that is a pretty common experience and people know about, right? Because people talk about that. They talk about that fairly openly. And I know there are lubricants to address that, but are there creams and hormones to address that to help, like Premarin and other medications that perhaps people I know may have a prescription for that?
Yeah, exactly. Yes, all of the above. There's lubrication, of course. Some women are really lucky and they never get that drastic dryness, that feeling of tearing when you're having penetrative intercourse and, feeling like sandpaper down there, itch. It just can be really
But does
awful for some women.
but if you don't have a natural lubricant and you're using a, a lubricant and you're having dryness, isn't it a different sensation if you produce it naturally versus a lubricant?
I know from my patients that some of them don't even realize they have dryness and they have recurrent urinary tract infections or urgency, which happens when your estrogen levels decline. I give them a little vaginal estrogen and it's like a game changer. They didn't even know they needed it and now they just feel so much better, and sex is definitely better for those women. But for those women that feel knives, while they're having intercourse, or they're just, you know, their husband is hands off because they're just in too much pain, a little vaginal estrogen goes such a long way. And I'll tell you how to apply it if you want, because,
I'd love to hear about that. When you say vaginal, you mean you put it right up there with an applicator? Is that what you're talking about?
well, typically for my patients, honestly, if you're having pain with deep penetration, which most women who have atrophy from not having their hormones, meaning they have atrophy from menopause, they don't need it all the way up there. They really need it around the opening and about 1 inch in. So all of my patients who I start on vaginal estrogen, I say that applicator, forget it. First of all, you're going to have to clean it. A lot of people think it causes infections on our own because you can't really get it that clean. And you have to set it on the counter for your husband to see it. And it's just not ideal. I usually say you put a blueberry size amount on your finger and you just rub it into the vaginal opening and rub it in like you're rubbing in your face cream or makeup so it gets absorbed. I've heard from women that when they use that applicator, sometimes it just kind of leaks out and gets messy in their underwear and it's not pretty. So if you do it like that, it gets absorbed, it gets to where it needs to be, and you don't have to worry about that applicator. So that's what I tell my patients. Blueberry size amount, rub it in.
How often does that have to be applied?
If you're starting a new prescription, I say 10 days in a row, get it going, get it in there, and then 3 times a week, Monday, Wednesday, Friday, or whatever works for you.
And that will address the dryness.
Dryness, usually it helps with symptoms of urgency and frequency, which women get. We call that genitourinary syndrome of menopause, that urgency, frequency, feeling like you got to pee all the time. A little bit of estrogen makes that go away. And for me, especially the biggie, recurrent urinary tract infections. The first thing I do in a postmenopausal woman is vaginal estrogen, and the infections go away completely.
So the other thing that I've read about that happens is actually you close up. I don't know how else to say that, but women who haven't had sex for a long time, you shut down. I mean, nothing goes in there.
Yes. So that that really ties in with atrophy. And for some women, it's just the pelvic floor. The pelvic floor can get really tight. If a woman is having trouble with penetration, whether it be a young woman who has vaginismus, which is a condition where your muscles are so tight that you can't even get a tampon in, or an older woman that just hasn't had intercourse in a while, pelvic floor physical therapy kind of sounds frou-frou. Every time you hear physical therapy, you're like, oh, that's, oh, I have a bad back. They wanted me to go for physical therapy. Pelvic floor physical therapy is really a game changer
Wait,
for some
you do
women.
physical therapy for your vagina?
Yeah, pelvic floor.
Like what do you do? I mean, what kinds of things are
There are pelvic floor, there's physical therapists that specialize in the pelvic floor. They do a thorough exam of all the muscles of the pelvic floor, which there's many of them. They identify the ones that are too tight or too loose. If you're having incontinence, they may work on tightness for some of them. But for women with, difficulty with penetrative intercourse, they'll use dilators. There's vaginal dilators. There's pelvic wands that specifically work to open up and relax muscles. So that is a whole another conversation. Pelvic floor physical therapy is huge.
I've never heard of this. This is extremely enlightening. What other things go wrong? Because, one of the things that this listener reached out to me about, and she was kind enough to sort of write down all her concerns because it was anonymous. She said, one of the biggest things is that you don't want to disappoint your partner. They don't want to disappoint you. So you just stay away from it for so long that you don't even know how to approach it. So you go to your doctor and you find out there's other things. Like she was telling me about this thing called lichen sclerosis. And she was saying there's actually treatments that you could do on your vagina. The equivalent sounded like a facial to me, but on your vagina. So talk to us about those things if you could.
So the first thing you mentioned, lichen sclerosis, is a skin condition. And it leads to severe dryness and itch. And it happens to the vulva. So the area that's the outside of the vagina. And that specific person probably had a lot of pain just from that alone. And in addition, that she's postmenopausal. So she likely got a steroid cream plus a hormone cream. And then, alternative treatments like you're alluding to are vaginal treatments that we now use technology like laser and radio frequency and high intensity focused electromagnetic energy to rejuvenate the vagina.
Wait a second, I'm going to stop right there. First of all, these conditions just happen with age and postmenopause. Nothing triggers them.
So lichen sclerosis is sort of a different entity, and that can happen at any age. And it's a precursor to some cancers. So it's a good thing if you have those symptoms I just mentioned, severe itch, especially if you're younger and not postmenopausal, pain with intercourse, and it usually presents as like a white patch on the vulva. Your doctor should really know to look for it, but sometimes it just flies under the radar unless you have, an astute GYN or urologist who's looking for it. A little bit of steroid cream, as I mentioned, goes a long way for that condition. And as I mentioned, it is a precursor to some cancer. So important to keep that on people's radar, but it's more rare. The masses are suffering from postmenopausal genitourinary syndrome of menopause, not lichen sclerosis.
Okay. So let's talk about the treatments one can do tantamount to going to a spa for your vagina. So
right.
This is also fascinating to me that you could rejuvenate your vagina just like you could rejuvenate your face or neck with Botox or treatments.
That's exactly right. And Botox is definitely plays a role in some other rare conditions, just because you mentioned it, where people have really tight pelvic floors, like we were talking about before. You could Botox that to really loosen it up. But the main treatments that I think we want to focus on are the laser. In my practice, I use Mona Lisa Touch, and it's a CO2 laser that works exactly how a laser would work on your face. We cause micro trauma to the tissue with that laser energy. And then just like you would on the face, you beat up the face and you have this red and angry and swollen skin. And then a week later, all that skin falls off and you have this beautiful, fresh, new baby skin. Similar in the vagina. It's a little quicker of a recovery process. It's usually 48 hours of downtime, no tampons, no intercourse, nothing in the vagina. But it essentially does what vaginal estrogen does without the need to use a cream every day or every 2 days. It increases vaginal lubrication. It decreases painful intercourse. It helps with recurrent urinary tract infections. I feel very comfortable recommending this to anyone who has that genitourinary syndrome at menopause, because in my practice, I can faithfully say that pretty much every woman has a positive result. And it's a little bit of a controversial treatment. I'm not going to lie. There are some people who think, it's there to make money and that it can have adverse effects. I'll honestly say I haven't had a single patient who haven't had an adverse effect, and most people are very satisfied after doing it. So it's something that I think is great.
Some people think Botox is controversial, and it's fairly, widely used at this point. But when you're talking about the Mona Lisa touch or the laser, are you telling me you kind of get right up there, down and dirty, and do it right inside, or is it the outside of the vagina? Because it sounds interesting.
I can try to give you a visual. So imagine a 6-inch phallic structure, like a dildo. So that long. And at the end of that, there is a laser fiber. And so what we do is we insert that all the way into the vagina. So for some women, that first treatment is uncomfortable. And we don't really like to use lube because it can interfere with the laser.
It's uncomfortable because nothing's been up there in a while.
Because they're dry. And that's what we're aiming to increase the lubrication, and we're not using lube. So we're putting in, it's not very thick. It's probably 6 to 8 inches thick. So it's not huge, but for some women, that's a lot. And so that first treatment can be uncomfortable. So we put this 6-inch thing in, and then we fire the laser in circumferentially, so 360 degrees around the vaginal mucosa, and slowly back it out. So 1 centimeter at a time. And you're treating circumferentially. The whole treatment takes 5 minutes. But if you can imagine, that's sort of what we're doing. We're working from the inside out. We treat the entire canal. And then, the patient really doesn't feel much until you get to right where the mucosa meets the skin, like the inner labia. Then they start to feel like that rubber band snapping sensation. Other than that, vaginal mucosa, believe it or not, they don't feel that laser energy, which is amazing. And usually the second treatment is much more comfortable because they have lubrication now. It works that fast.
Wow. And how many treatments does one need generally?
3 treatments spaced 6 weeks apart. So the entire cycle is 4 months.
And how often? How many years do you need it again, or is it one-time treatment?
Good question. I have patients that do it once a year as a booster. Some people can go a little bit longer. Others like to do it every 6 months, but that's pretty rare. It's usually 1 booster treatment a year.
And then you get going again, and then, you kind of kick in, so to speak.
You shouldn't, unless you leave a long lag, 3-4 years between treatments, you shouldn't ever need 3 treatments again.
So if you haven't had sex for a long time and then you start having sex, you might need something like the Mona Lisa touch or vaginal cream or something to get going. But if you haven't had sex for a long time and you do a kickstart, is having sex regularly going to avoid you drying up again or the blockage again, or no? Because does sex itself promote vaginal health? Is that a reasonable question?
I would say if you're not having sex for a long time, then, you're probably going to be, for the not a great word, tighter.
You're having sex regularly again. If you kick it up, you say, okay, I'm back in action. Do you stay lubricated? Do you generally stay ready for action?
Typically, if you're postmenopausal, no, you're going to need something. Unless you're one of those lucky people. There are obviously women out there that don't have painful intercourse or don't have dryness and have great sex drives. They're like the unicorns. Most of us are not like that.
So there used to be studies. I remember there was a big fear, maybe when I was in my 40s or 50s, about vaginal creams and estrogen and cancer. And women were staying away from it. Now, by the time it was ready for me to use those studies, my gynecologist said, I'm not particularly concerned about them. You have anything that you want to enlighten us about with regard to the use of estrogen and cancer and those studies that scared a lot of people years ago?
Yes, I still have this conversation multiple times a day. Unfortunately, those studies you're talking about in the early 2000s were very flawed. They had elderly patients in the studies using hormones that were derived from horses and oral hormones. And all of these things we know are not safe anymore. You don't give older women high doses of oral estrogen derived from a horse. I wouldn't give that to, a perimenopausal woman. And unfortunately, those studies made it to the cover of Newsweek magazine, and every woman in every household who was on hormones called their doctor and said, "How could you do this to me?" And then hormones were condemned. Well, they reworked the statistics. They were all flawed in that study. And they identified the fact that, we were using bad hormones, and they had elderly women in this study who were going to skew all the data because older people have more medical issues. They have blood clots and they develop more cancers when you're 80. So now we actually think that hormones protect against cancer. They protect you against cardiac events. They are good for your bones and your skin and your youth. And I'm a huge proponent of hormone replacement, if you couldn't tell.
Yeah, but it is a different conversation now than it was 20 years ago when I was addressing those issues, because women were terrified, and the word on the street was, well, is it worth my health to have sex? And many people decided no, and they closed down shop. I know a lot of women who just have closed down shop. They say, well, I don't want to get breast cancer. And, it really changed the relationships with many people or their whole sexual identity. It did. It was an interesting time.
And it's a huge uphill climb to get rid of this stigma. Like I said, I have this conversation multiple times a day with women because somewhere, some doctor, some old school doctor, even new doctors, even young doctors, they just think hormones cause cancer. And the only person I wouldn't give hormone replacement to is someone who had active breast cancer, that, they're treating them for breast cancer and they're extracting estrogen from their body so that it doesn't feed the cancer. That's the only person who really is not a candidate for hormone replacement therapy. Women go through hell in menopause in some cases: hot flashes, night sweats, all these sexual symptoms, urinary issues, weight gain. They can't sleep. It's not good. It's not good for anyone. So I really am a huge fan of hormone replacement. And if you are active on social media at all and follow some of the doctors in this field, we're all sort of on this same page that we have to break the barriers. And the other thing I want to mention quickly is that vaginal estrogen, and this is how I start the conversation with those women who are like, oh no, no hormones. I say vaginal estrogen is not absorbed systemically. It is only a local vaginal treatment. It doesn't get into your bloodstream. I'm not slapping an estrogen patch on you or giving a hormone pill or a pellet. It is just a vaginal treatment. It's not going to make your hot flashes go away. It's only to help you with your urinary and sexual symptoms. Usually that puts those patients at ease that are just really on edge about the estrogen because their mother had breast cancer or their aunt had breast cancer. So that's one way that I sort of scoot around that with the women that I know I'm just not going to get through to them.
So with the vaginal estrogen, and you might have addressed this, forgive me, but it not only, of course, it helps with the mechanics of it, the lubrication, but does it help with the desire as well?
No, honestly, no.
So it just helps with the ability to have it happen.
Well, indirectly, maybe, right? Because if you're no longer having pain with intercourse, you're probably going to want to have it more, or at least
Good
be
point.
more open to it.
Yeah. And enjoy it more, certainly. It's interesting. What is your experience with women of a certain age talking to you and their comfort level? I mean, you're a young, accomplished physician. What has been your experience with women being able to open up to you about this topic? Because it is taboo and it is embarrassing and it is uncomfortable, particularly if you're going through the symptoms of menopause, of weight gain, body changes. How does that conversation happen?
It's twofold. Right now, I am experiencing that in my practice. The word is sort of out in my region that I'm doing this. And a lot of people are getting referred for this and have seen my social media and know that it's probably going to be a comfortable conversation just because, as you pointed out, like I don't censor anything. So they already come in feeling like they can talk to me about it. The flip side of the coin is that I see a lot of older women with urinary tract infections or kidney stones or incontinence. They're not there to talk about sex, but I pretty much made it a point to ask every single woman if they're sexually active.
Are they
That,
uncomfortable answering that? I think there might have
you
been a time where I would have been uncomfortable answering that when I was, not sexually active after my marriage ended and before I dated. I think I might have been. I mean, I'm sure I told my gynecologist, but that's not a particularly comfortable conversation for women of a certain age.
Sometimes, yes, I can tell they either say, sort of, or a lot of times it's, I'm sexually active, but I don't have intercourse. So they're doing other things because they can't, right? They're like in too much pain, or, they have too much dryness. They can't even, or their husband has no erection. So I see a lot of that. I see a lot of, we're sexually active a little bit, but we're not having like sex. But I can usually sort of frame it that, oh, like if I say, you're here for your recurrent urinary tract infections, and I say, you're sexually active, and they say yes, I say, do these infections happen after intercourse? Or how is intercourse? Is it okay? And sometimes they're like, no, it's harm. I just do it because my husband, whatever. So that does lead to other things. And at least a couple of times a day, I start talking about things like Vyleesi or Aggie or oxytocin, which we haven't really talked about, or Mona Lisa Touch. And most of the women are like, what? Like this all exists? Who knew?
Tell me about oxytocin.
Oxytocin is the love hormone. So it's another neurotransmitter in your brain. And we prescribe it as either like a sublingual under your tongue dissolvable tablet or a nose spray. And it increases arousal and orgasm.
Ah, the orgasm. Let's talk about that. Do women
Yes.
share with you their ability, inability, have conversations with you about orgasms or not having them or having them? And is that part of what you address medically?
Yes. And, I mean, that's definitely not as common as the vaginal dryness and the low libido. But I do have women that, say, I have intercourse, but I don't really, get off, or I don't have an orgasm.
So, how do you respond to that? I mean, I'm fascinated that you have these conversations with as much openness as you do, but how do you respond to that medically?
I
Or as a
usually say,
professional?
we have some options. Oxytocin is not really my go-to for that. Testosterone is. So then that opens up the box of testosterone, which we really haven't talked about much either. Women's testosterone starts to decline in your 30s. So there are some women who are young with low levels of testosterone that aren't probably having great orgasms, or maybe even have low desire. And testosterone is not FDA approved for women. It should be. There are millions of prescriptions written every year, but we still can't go to a regular pharmacy and give women testosterone. We compound it. So we make creams, and we make pellets, and we make troches or lozenges. And it helps with libido. It helps with orgasm, and it's safe. There's virtually no side effects unless you get really too high levels, and then, they can grow hair and their voice can deepen. But it helps with energy, weight loss, that menopause belly that women complain about, that extra belly fat that happens as you go through menopause. And there are some women who I just prescribe menopause, no estrogen, no progesterone. Oh, I'm sorry, menopause, just prescribe testosterone because that's all they need.
I am fascinated with the level of exploration and options that you're explaining to us that are available for women. Because again, I talk to people all the time. I'm a divorce lawyer. I have a podcast. I'm extremely involved with conversations with people because I'm always curious about relationships. And I have never had a conversation at this level about women's sex. It's just unheard of, or that there are options to fix it. I just know lots of women my age who just, as I said, they're closed up shop. They're done. Business is shut down. And, this really, in my mind, opens up a whole new possibility, a whole new world. And I'm so encouraged by this conversation for myself and for others. So this is just really enlightening.
I really think you're right too. I don't have any notes in front of me, and I've been doing this a while, so it's just very comfortable. But in the back of my mind, when I sat down, I was thinking there's so many options. I'm going to forget something. I do have a list of things in my phone in case I've like tried everything on someone and I want to look to see what else I have. I mean, there's supplements like ashwagandha, maca root, rhodiola. There's all these things that you can try that are sort of natural libido enhancers, orgasm enhancers. There's peptides now that people advertise that you can
All right, so we
inject.
should be taking out billboards as women and advertising this. I am telling you, this is just untapped stuff. If I see one more bent banana or whatever on a billboard or on morning television, we're talking about that. The erection's a big topic. But isn't it amazing that these conversations aren't in the public sphere? aren't being talked about on morning TV or evening TV. But it is a real interesting observation that we are confronted with, as I said, bent bananas and erection issues all day long and pictures of people going and having sex, but it's always about the erection. This is an area that I'm telling you, we should be singing this from the rooftops.
Yeah, I have a partner at my practice, a man who for the last few years, I started like 6 years ago, but about 3 years ago, he knew that this was just going to be
Boom.
a booming field, and it really is. So it's not something that the public is seeing yet, but it's on the brink of really becoming something, first of all, extremely lucrative, I think. I mean, I think people are going to be looking for these drugs and these drug companies that have these two drugs, the Addy and the Vyleesi, especially for low libido, they're just going to be like this semaglutide and Ozempic, the next thing, I think. So, it's definitely something that's not mainstream just yet, but it's about to be there.
Oh, this is going to be revolutionary, in my opinion. I'm hoping our podcast helps get the word out because I think this is extremely exciting. I think this is extremely informative. And I'm looking forward to sharing this knowledge because I do think you're on the brink of something. So I thank you so much. Are there any red flags or conversations that patients should be aware of when speaking with their healthcare provider that should make them cautious of the advice they're getting?
Anyone who's pushing those procedures right off the bat, like anyone who's like, you should do a laser or you should do a radio frequency treatment or you should do this, they're probably in it to make a buck. That's number one. And number two, anyone that's like patting you on the back and telling you menopause is a fact of life and that you should just deal with it and have a glass of wine, honey, that's like huge red flag.
Thank you so much for joining us today. Don't forget to follow us on your favorite podcast platform. Please give us a 5-star rating and leave a review so more people can listen in to Heartbreak and Hope with Pat Barbarito.